Welcome back to my channel. Today we are covering myasthenia gravis, an autoimmune condition that disrupts the way nerves communicate with muscles. By the end of this video, you'll understand what causes it, how it presents, how it is diagnosed, and how it is treated. So what is myasthenia gravis? It's a chronic autoimmune disease of the neuromuscular junction. To understand it, let's begin with the neuromuscular junction, the key structure affected in this disease. This diagram shows us how nerves normally activate muscles. This is the nerve site, and this is the muscle site. Here at the nerve ending, called the axon terminal, there are synaptic vesicles filled with a chemical messenger called acetylcholine. When a nerve signal arrives, these vesicles release acetylcholine into the small gap between the nerve and the muscle. It's also known as the synaptic cleft. On the muscle side, we see nicotinic acetylcholine receptors here. When acetylcholine binds to them, it triggers the muscle to contract. In myasthenia gravis, the immune system produces antibodies that mistakenly attack these acetylcholine receptors or sometimes related proteins like MuSK instead of attacking the germs. With fewer receptors available here, the signal from the nerve to the muscle becomes weak and unreliable, thus resulting in impaired neuromuscular transmission. This leads to the hallmark feature of myasthenia gravis, muscle weakness that fluctuates, worsening with activity and improving with rest. Now, let's see what the causes and risk factors are. The cause is autoimmune. The majority of patients have antibodies against acetylcholine receptors, like I have explained in the previous slide. Others may have MuSK or LRP4 antibodies. Myasthenia gravis is also associated with abnormalities of the thymus gland in our body, such as thymic hyperplasia or thymoma. Symptoms can be worsened or triggered by infections or starting medications such as aminoglycoside antibiotic or beta blockers. Myasthenia gravis follows a bimodal age distribution, often affecting young women under 40 and older men over 60. So what are the symptoms? Clinically, myasthenia gravis most often begins with symptoms in the eyes, drooping eyelids, which is also known as ptosis, and double vision called diplopia. Bulbar involvement can cause dysarthria, which means slurred words, and dysphagia, meaning difficulty chewing or swallowing, and nasal speech. Patients also develop weakness in the arms, legs, or neck. The most dangerous complication is when the respiratory muscles become weak, putting patients at risk of a myasthenic crisis. A myasthenic crisis is a life-threatening complication where severe weakness makes breathing impossible without support. It is often triggered by infection, surgery, or medication changes. These patients need intensive care, sometimes mechanical ventilation, and urgent treatment with intravenous immunoglobulin or plasma exchange. Diagnosis starts with a clinical picture, fatigable weakness that improves with rest. Blood tests can detect antibodies against acetylcholine receptor, MuSK, or LRP4. Electromyography, especially single fiber EMG, shows the characteristic drop in muscle response with repeated stimulation. Imaging of the chest with CT or MRI is essential to look for a thymoma. For ocular cases, a simple ice pack test can temporarily improve ptosis. Now let's see the treatment. Treatment is twofold: controlling symptoms and modifying the immune response. For symptoms, the main drug is pyridostigmine, which prevents breakdown of acetylcholine, allowing more of it to stimulate the remaining receptors. To dampen the autoimmune attack, we use immunosuppressants such as corticosteroids, azathioprine, or mycophenolate. In severe or resistant cases, targeted therapies like rituximab or eculizumab can be effective. If a thymoma is present, surgical thymectomy is recommended. And in crisis situations, intravenous immunoglobulin or plasma exchange can rapidly improve strength. Now let's see what prognosis looks like. The prognosis today is generally good. While myasthenia gravis is a chronic condition with periods of relapse and remission, most patients respond well to treatment and maintain a good quality of life. Early recognition and avoiding triggers and appropriate therapy are the keys to long-term control. Myasthenia crisis is potentially fatal but treatable. To summarize, myasthenia gravis is an autoimmune disorder of the neuromuscular junction caused by antibodies that disrupt acetylcholine signaling. It presents with fluctuating fatigable weakness, often starting in the eyes and bulbar muscles. Diagnosis relies on antibody testing, EMG, and chest imaging. Management includes pyridostigmine, immunosuppressants, thymectomy when indicated, and emergency treatment with intravascular immunoglobulins or plasma exchange during crisis. Thank you for watching. If this was helpful, subscribe for more clear and concise medical explainers here at BT Medicine. Bye bye.